Hi, folks. So we are recording, even though class technically doesn't start until 10 o'clock. At least we're getting this out of the way. Anyone else can't write their names in the chat meeting box?
I feel like it has something to do if we were in Med-Surg 1 or not. It seems like a lot of people are not like new people. It seems like it's any of us that were from before.
All right.
Felicia's trying to get in, Dr. Weaver.
Felicia was kicked out again? I thought she was in this morning. At least
She just texted and said that hers is connecting.
Oh, all right. Thank you. I thought I saw Miss Lynch.
I'm here.
All right, great. Thank you. All right. And I thought I just heard the Miss Durham.
Yes, sir. Good morning. I'm here.
All right. All right. Let's see who else. Miss. Amanda Gregg. Brenna Rawls. I think I saw Mr. Allred already.
Yes, sir.
All right, thank you, sir. Mr. Wolf, you may have Carlton Mai.
Yeah, Mr. Martin's been in the classes this week or last week that I saw.
What was that?
Paul Wolf hasn't been in any of the classes that I've seen, at least in our group studies, and then he wasn't in mental health either.
Really?
I keep getting kicked out.
Is that Miss Carter?
This is Miss Morales.
Oh, Miss Morales. All right. All right, I got you. Hopefully I'll be able to get you guys back in fairly quickly. Mr. Allred, you said Mr. Wolf wasn't here last week or this week.
Right, he wasn't in the mental health class or the thing, and then he's supposed to be in Group A, and he wasn't with us Monday or Tuesday in the clinicals.
Yeah, I believe we I want to say.
You say you talked to him, Ms.
Talked to him over the phone. Yeah, he said that this class tile didn't load for him, but I told him that you was calling his name in attendance and he should call the school. I don't know if he ever did that.
Wow, that's interesting. Yeah, he should certainly do that. Get a hold of me or something. I mean, so he's still in the program?
Yeah, he's still in the program, but he has some other classes.
Huh. So I guess I'll reach out to Professor Thody as well, because she's probably. The destination is on your right. Yeah. Is Miss Wooten here?
Yeah, I'm here.
All right.
I put in the comment box my name. It did go through for me.
Or did go through?
Yeah, I did.
Maybe I didn't go up high enough. Oh, there
Yeah,
it is.
I was
I see
the
it.
second one. Okay.
I see it. Thank you.
I can't type in the comment box.
You can?
No.
And what's your name?
Felicia Singh.
All right. All right, I got you. Let's see, who else am I missing? D'Angela Austin, you typed.
I'm here.
All right. Yeah, my camera wasn't working yesterday. So, I mean, there's all sorts of issues with this thing. But I had to work on it last night and, you know, finally was able to get it working. Let's see, who am I missing? Huh, that's the wolf. All right, let me make a note for myself. Oh, he said his class tile won't load. It's not loaded.
Yeah, that's what he had some issues with some other classes, but I'll let him tell you about that.
Yeah.
But it did say that this class tile never loaded.
All right.
Okay.
All right. All right. I think that's pretty much everyone except Mr. Wolf.
Dr. Weaver, do our video cams need to be on right now?
No, you don't.
Okay, thank you so much.
Yeah. I know some people don't feel too comfortable about being on camera. I mean, usually in staff meetings, I'm not on camera. And so for the purpose of attendance, it's good to do initially, but not required to stay on indefinitely or throughout the class. Just want to make sure I got everything.
We appreciate it.
You know, and I thought I noted him, Mr. Wolf, here last week. Let's see, did I? Anyway, need to correct that. So he missed clinical. That's going to be a tough one. Hold on, you all, please. I just want to shoot Professor Foley a message quickly. Right. All right, so we were able to finish up with, well, what I was able to cover dysrhythmias last week. And of course, there was some additional information that I told you all that there are some voiceovers for you to listen to. And of course, as I mentioned to you, I do that so that I can spend more time on those topics that are a whole lot more complex. So this week, we're going to, or today, we'll just focus on heart failure. And of course, the remaining information is on voiceover as well. So hopefully we'll be able to take our time enough so that you all will really get this disease process ingrained in your heads. Almost be like second nature to you, hopefully. Now, I know I mentioned last week that I know we have different learning styles. We have students with different learning styles in class. And for that reason, if you don't want to stay on for the lectures, and if you just want to do some concept maps that I will assign, you can do that. And of course, those who wish to remain, you can, of course. If you decide to do the concept maps, they would be on 3 relatively short topics, but it would have to be on atrial fibrillation, VTAC, and ventricular fibrillation. And those are on page, AFib is on page 678. And VTAC and VFib is on page 684. Like I said, they're relatively short, but they will give you an edge as far as your dysrhythmias are concerned. Or again, if you want to stay on, you can do that too. You can do a combination. Maybe you want to do maybe one of these and get back on for some of the other parts of this lecture that I'll be going over. It's up to you.
Quick question.
Yes.
Concept maps for 3 subjects. Do you need to or do you just email?
I'm sorry, say that again, Ms. Kate.
We just emailed them to you?
Yes. Now, are you aware that when you do the concept maps, if you're not constantly saving, it'll, in the end, it won't save the whole thing. It'll kind of like just make everything go blank.
So if you end up using the Microsoft version, the Microsoft 365,
Mm-hmm.
365, it automatically saves for you consistently, and I've never had a problem myself not saving.
All right, great. However way you can do it, it's fine with me. And just, you can just email that to me. And
By which time?
by the end of class. Well, 5 o'clock.
Oh, okay, thank you.
Yeah, sure.
All right, thank you, everybody. Bye.
All right. Anyone else wish to do concept maps today?
I don't, Dr. Weaver, but I do have a question.
Yes.
So basically you would tell us, we're going over this topic first in class, and I could say, oh, I want to do a concept map, and you'll give it to me, and I would log off of live chat and do it and turn it in. And then if I wanted to actually live listen to the second 2 topics, I can do that.
Well, the topic we're covering today is heart failure. It'll pretty much take up the whole time. Right. So whatever part you want to come in at, or if you just want to do all the concept maps, which is 3 of them, that would be your choice.
Okay, and that would give you attendance credit?
Yeah. Mm-hmm.
Okay, I'd rather listen, but I was just curious.
Yeah. Either way, what I'm doing and, as far as the lecture, actually, well, I probably shouldn't say this, but, we're actually recording the lectures. Well, you all know that. And so I put these in the HESI tile. I want to say, as soon as you log into the HESI tile, it's near the bottom where it says recordings. So, I mean, even if you did want to do a concept map and then come back and, listen to the that part of the lecture later, of course, it could be a little longer, so it's up to you. Anyway, anybody else have any questions?
So how many concept maps do we have to do in lieu of the lecture?
It's 3. They're relatively short, but it is 3. It's you got the subjects, atrial fibrillation, VFib, and VTAC.
Can I do that?
Yeah, if you want to do that, that's fine.
Okay, so AFib, VFib, and what's the other one?
Ventricular tachycardia.
Okay.
And that's
good.
page 678 and 684.
Okay, sounds good.
All right.
All right.
Let's see. So we are going to get started. Can you all see this? My PowerPoint?
Yes, sir.
All right.
Yeah.
Me too. I can see it too.
I
All
can
right.
too.
Good. Let me make sure I can. All right, that seems to be working. All right, so again, this is our topic for today will be heart failure. It can be found at the beginning of chapter 35 and care of patients with cardiac problems. I will let you go ahead and read the objectives at your leisure. Now, heart failure is a very common reason why people over the age of 65 is admitted to the hospital in this country. When the heart is diseased, its ability to pump arterial or oxygenated blood to our vital organs is compromised. And of course, these organs and our tissues, they receive little to no nutrients as well. Essentially, the vital organs such as our brain, our kidneys, peripheral tissues are deprived of all the essential elements, nutrients, oxygen, and without adequate nutrients, these organs will not function well and they will fail eventually. So when you think about the function of the heart, the anatomy, physiology, the function and whatnot, it's important to note that it is how our body organs, our vital organs, our peripheral tissues do receive its supply of some really important things such as our nutrients and oxygen and so forth. And as you can see, without adequate perfusion, and this is really all mostly about perfusion, that is really the main priority concept here. These patients who develop heart failure, and by the way, heart failure is actually technically not a diagnosis, but essentially it is a constellation of symptoms, a variety of symptoms, because the heart has failed as a pump. Now, I will tell you also that heart failure, it basically accounts for most of your readmissions. Upwards of 25 to about 30% of readmissions results from heart failure. It has become such a problem to the point that CMS or Center for Medicare and Medicaid, they actually give a reduced reimbursement to hospitals when these patients, when they go home and then they turn back around and come back within 30 days of discharge. So, and I know that doesn't sound very fair, because for a variety of reasons, these patients are actually coming back to the hospital. It could be because you have this elderly patient, maybe 70 years old, who is illiterate, cannot follow health information or the treatment regimen because they just can't read. So for a variety of reasons, these patients are coming back to the hospital. In other words, they may not have the support systems, and they may not be able to manage their condition either. So it becomes a vicious cycle. So your hospitals, they have in place certain programs to hopefully minimize these readmissions. And one of the biggest things that we must do is we must educate these patients in how to better manage their disease. There is a teaching method that I know I believe I mentioned to you all before, but it's referred to as the teach back method. And you can research this, but basically the teach back method is the nurse or the healthcare professional teaches the patient about their disease process, the treatment, the medications, and so forth. And then the patient or caregiver must turn back around and teach that information back to the healthcare professional in their own words. And that way, you know that they understand what you are teaching them. So that's why the teach back method is so important. It is just to make sure, in layman's terms, that you're teaching these patients about their disease process, and then they teach that information back to you. And then hopefully, once they get home, they can better manage their condition. I mean, you taught them, for example, about the signs and symptoms. You might tell them if you gain more than 2 pounds, then to take an extra Lasix, because this may be a part of the doctor's order anyway, where it tells the patient if you gain 2 pounds, because these patients are weighing themselves on the same scale every day, same time, same amount of clothing, of course, and they're instructed basically to take the additional Lasix dose, a diuretic, in order to minimize that fluid buildup, because that's what happens with these heart failure patients. Because the heart cannot propel the blood forward, it backs up into the pulmonary system, and then these patients end up in the emergency room, something we do not want. So there's a variety of programs out there. There's been so much research that has been done in order to try to minimize these readmissions. And it's not just heart failure, it's a few others. I think COPD, I think maybe pneumonia, but there are a few. And again, healthcare organizations receive a reduction in their reimbursement when these patients are readmitted. So it is important for you all to get a sound understanding of this particular disease process, because you will see it quite a bit. The demographics of patients that you will see in the hospital mostly are the elderly or people 65 years and older. Unfortunately, as we get older, that's where a lot of our healthcare dollars are spent, and that is on these patients who have chronic disorders and they require hospitalizations and whatnot. So that kind of gives you a little background on that. They go forward. All right. Now, this particular slide was probably, I want to say on slide 20 something. I don't know why they put it so far back, because I think this particular piece of information should be at the beginning before, as we begin to talk about heart failure, because it helps you to understand the therapies, if you will. We refer to your preload, afterload, and contractility as your hemodynamic regulation. And it is defined as the optimization of your heart rate, your preload, your afterload, and of course your contractility. Now I know I've thrown those concepts at you quite a bit. So hopefully you're feeling a little more comfortable as I begin to talk about it. Is there anyone who feels a little confused still about preload, afterload, contractility? Anybody? And please, does anyone feel confused about the preload, afterload, contractility?
Yes, I do.
You still feel confused about it?
Yes, sir.
All right. And this is Sylvia?
Yes, sir.
All right. All right. So let me go ahead and go through this information, and hopefully we'll be able to clear it up. Did you also read the materials that I sent you all as well?
Yes, it is.
All right. Yeah. All right. So now let me say this to you. Again, we're talking about hemodynamic regulation. Whenever we're talking about preload, afterload, and contractility, of course, we are talking about the heart in particular in this regard. And if you can understand this preload, afterload, contractility, then you'll also understand what the treatment regimen would call for. For example, with heart failure, as I mentioned, or forward failure, as we also refer to this disease system, the heart is not pumping effectively. You know, when the ventricles, when the left ventricle in particular squeezes, blood is supposed to propel forward into the aortic valve and into the aorta, and also into throughout the rest of the body. Now, if we understand again preload, afterload, and contractility, then for example, with heart failure, the preload. Actually, let me bring up. I'm going to bring up an image. I'm going to stop sharing here for a minute. Let's see, where is it? It'd be better if I show you an image. Put this over here. All right. Let me know if you can see my heart.
Yes, sir.
All right. Good, good. All right, so when we talk about preload, let's kind of just break it down here for a moment. When we're talking about preload, we're talking about the amount of blood in the left and right ventricle. Let's say if it's 100 cc's of blood in the left and right ventricle. Mainly we're talking about the left ventricle, but preload and afterload, preload it can be, the left and right ventricle does have preload. That's what I'm trying to say to you. All right, and it's just the amount of blood in our ventricles. All right, Miss Sylvia, do you got that? Do you have that part so far?
Yes, sir.
All right, so that's the preload.
Preload is, you said, is the amount that we have in our left ventricle?
Left and right ventricle.
Okay, for both. Okay.
Left and right ventricle, but mainly we're talking about the left ventricle though, mainly. But just know that it's left and right ventricle.
Right.
Got that?
Yes.
Now, do you guys see where I have this red mark?
Mm-hmm.
All right, now that's supposed to be blood, all right? But that's red, meaning it's oxygenated arterial blood. Because remember, when blood returns back from the lungs, it's now oxygenated. And so this is oxygen-rich blood here in the left ventricle. You guys got that?
Mm-hmm.
And you see this, well, it's kind of purplish, but just kind of consider it bluish. All right. So this is in the right ventricle. And can you tell me why this blood is blue over here?
Not oxygenated.
Because
It's oxygenated
blood.
What did you call it?
It's oxygenated.
Which one is oxygenated?
The red one.
All right, that's oxygen. And which one is this one?
Deoxygenated.
Yes, ma'am. Right. So this is your deoxygenated blood because it is coming from the right side of the general circulation. Because remember, once the blood goes out of the left ventricle and throughout the rest of the body to our organs, to our tissues and so forth, to provide oxygen, to provide nutrients and so forth, it gives off its oxygen, its nutrients and everything, right? And now, so this blood will now, once it gives off, and this is kind of without making it too complex, but basically, once everything is delivered, your oxygen, your nutrients, and so forth, then you have your deoxygenated blood. Now it's deoxygenated because it already has fed the tissues and organs and whatnot like it's supposed to. And so this blood now is returning from the right side of the body to get oxygen again. You all understand that?
So it's returning where?
All right, it's returning from the right side of the body. To the inferior vena cava and also to the superior vena cava. All right. Okay. Let me do it this way. All right. So follow my cursor. So this is oxygenated blood because this blood has gone through the lungs, right? When it goes through the lungs, you have the alveolar capillary membranes, and that is where oxygen and CO2 is exchanged. You got that? Mm-hmm. In other words, when this blood coming from the right side goes through the lungs, it is going to you're going to expel or exhale CO2, and you're going to inhale oxygen, and this is what causes this blood to become red, if you will, right? And so this blood is being brought back through the pulmonary vein into the left atrium, through the mitral valve to the left ventricle. All right. Now this is, again, oxygenated blood. When that ventricle squeezes, it pushes the contents through the aortic valve, through the aorta, right? So all of your organs, all of your tissues are going to receive this oxygenated blood. You got that, right?
Mm-hmm.
But now, once it gives off that oxygenated blood, it's no longer oxygenated, right?
Right.
So if you want this blood to become oxygenated again, it can't go back to the left side, so it has to come back to the right side in order to go to the lungs again. Like a cycle, you know what I mean? So this blood is coming from all of your vital organs, you know, the waste, if you will, the waste, your tissues, your organs. This blood that is now deoxygenated because it already has delivered. You know, your vascular, your veins, or your arterial system is actually what delivers the oxygenated blood. But it is your veins that collects this deoxygenated blood and brings it back to the inferior vena cava from the lower part of the body and the superior vena cava from the from above your heart, you know, your head and so forth. You know, it has to, all this deoxygenated blood from the venous system, your veins, are now being dumped into the superior and the inferior vena cava. Got that so far?
Yes.
Anybody confused about that?
Mm-mm.
No.
See the right side is the venous system. The left side is the arterial system. Right?
Right.
So now, see, the right side of the heart, or the venous system, is now transporting this blood back to the right atrium, which goes through the tricuspid valve and into the right ventricle. From the right ventricle, the right ventricle will squeeze, and this blood is pushed through the pulmonary valve, because now it's on its way to where to get oxygen.
On its way to the right side of the heart to get oxygen, right?
All right. So this blood that's leaving the right ventricles and going into the pulmonary artery, where's it on its way to?
To the lungs.
Right. It's on its way to the lungs. And why is it on its way to the lungs?
To become
The
oxygenated.
To get some oxygen. Because when you inhale, you're bringing in oxygen. When you exhale, you're giving off CO2, waste. That's your waste. You're inhaling, you're bringing on oxygen. So now that blood that was bluish now turns what? What color?
Red.
And it is brought to the pulmonary, it leaves the lungs to the pulmonary vein. From the pulmonary vein to the left atrium. From the left atrium, this is now oxygenated now. From the left atrium to the left ventricle and right back out into the systemic circulation.
So basically, just going through the whole cycle.
Yeah, it's like a cycle.
Yeah.
Right. Now this is important because, as you can see, now follow my cursor here. So everything is going this direction. Well, it's coming from the inferior superior vena cava here, and then to the ventricles, and then to the pulmonary artery, to the lungs. See, this is all going forward, all going towards the left. That's the whole goal, is going towards the left. To the left side, all right? But in heart failure, it does what? Follow my cursor.
To the left.
It's backing up. It's backing up, right? It's backing up, right?
Right.
See, it's backing up. See, the left ventricle is supposed to propel the blood forward. All right, but if the heart muscles are impaired and your heart fails as a pump, this blood is not going forward, it's going what? Backwards. All right, y'all have that so far?
Yes, sir.
Now, so I had to kind of go through some of your anatomy and functions and whatnot to make this better understood. Now, when we talk about preload, that volume of blood that is brought from the pulmonary vein through the left atrium to the left ventricle, that blood, that is your preload, right?
Mm-hmm.
Now, this is the left ventricle muscle, the myocardium. It's very thick. This side is much more thicker than the right side. Why is this side much more thicker than this side?
Because it has to pump blood throughout the entire body.
Exactly. Exactly. It's dealing with a whole lot greater pressure also because of that arterial pressure versus venous pressure. Arterial pressure is much more higher than your venous pressure. All right. So this preload here requires this large muscle to squeeze enough to eject it through the aortic valve into the aorta. And this is what we call that pressure, that afterload. All right. So this is the preload that must overcome that afterload pressure. So when someone has hypertension, this afterload, which is, when you think about hypertension, it is your arterial pressure is just very high because these blood vessels are clamped down. They're clamped, they're tight, they're constricted. So just imagine this being constricted peripherally, you're constricted. And so that increases your afterload. It's the amount of force that this left ventricle must overcome to eject its preload. All right.
Oh Lord,
Say again.
You said hypertension is when the blood vessels are constricted. It's too much arterial pressure, right?
Right. The arterial pressure is too high, so that you're mostly clamped down. You're constricted. And see, this is why when we get into some of the drugs that we talk about, what you're trying to do is dilate the arteries. Okay, because the more you dilate, let me come off of this. All right. So just take a look at my hand. So when those blood vessels are, let's say, for example, this close, your blood pressure is much more higher because there's more clamping. All right, there's more vasoconstriction. As these blood vessels dilate, right? As these blood vessels dilate, your blood pressure begins to fall.
Right.
Right. So with hypertension, those blood vessels are more constricted, and that is your afterload. All that pressure, when you're like this, your blood pressure is, let's say, hypothetically speaking, 200 over 120. When they begin to dilate, your blood pressure is now 120 over 70. Mm-hmm. Your left ventricle has to pump blood in a pressure of 120 over 70. That's fine. But when those blood vessels are very constricted, right? Mm-hmm. It's like trying to put water through a very small tube, and the pressure would be much higher as opposed to a much larger tube, which the pressure would be a whole lot lower. So in hypertension, which is really one of the biggest reasons why patients develop heart failure, because the heart over many years have had to pump against all that pressure. The heart cannot pump against that kind of pressure over a prolonged period of time without being adversely impacted. Does that make sense?
It does. I got my whole life.
I'm saying, sorry, say that again.
No, I was just speak. I have hypertension. I said I got to get my whole life together.
Yeah, yeah. And you know, it's a silent killer, as you all have heard, and you don't even know, to be honest. Your heart over all these years are just pumping against all that pressure, and the harder the heart has to work. Let me share again. The harder the heart has to work, the bigger this muscle gets. This muscle is getting bigger, this myocardium is getting bigger because it's trying to become strong enough to be able to push against all that afterload, all that pressure, right?
Mm-hmm.
Now, so we talked about preload being that volume of blood here. Sometimes this volume of blood is just too much, and your heart can only handle so much preload. So while I'm talking about it, this is why we began to talk about some preload reducing drugs. How do you decrease blood volume? What drug can we use? What is one of the main drugs out there to reduce blood volume or fluid volume in your body?
Blood thinners, right?
What was that?
Isn't it? It's
Rosamine or whatever, Lasix or something.
Lasix. Yes. Diuretics. Yes, diuretics. So diuretics can help us to decrease our preload, because too much preload for a heart that is already impaired is just too much for that heart. So sometimes we have to give these patients, I'm kind of jumping here a little because we're not talking about drugs necessarily yet, but yet we might as well go ahead and kind of hit some of those points so you can see why we talk about preload, afterload, contractility. So with the preload, if we have too much preload, if we have too much volume in here, then this myocardium, this muscle is stretching and stretching and stretching and stretching until it loses its capacity to give a good, strong squeeze. All right, it can stretch. The more it stretches, you get a more forceful contraction, a forceful contraction up to a point. But if it stretches beyond its capacity, that force, that contraction is going to be less. All right, it only has a certain capacity, just like you can only lift 50 pounds. If you have to go anything above that, you'll begin to strain even more until you hurt yourself, right? So the heart can only stretch, this myocardium can only stretch based on that volume, that preload, it can only stretch so much, all right? And when it reaches or it goes beyond its capacity, that contraction is going to be weaker. All right, so we want to give these patients some preload reducers, such as a diuretic. Now, this is a little tricky what I'm getting ready to tell you. So we know that a diuretic is a preload reducer. We know why, right? Does anybody not know why? We're just reducing volume. It's a preload reducer. It is a volume reducer. That's all that is. Now, sometimes we have to give these patients nitrates. Nitrates can also be considered a preload reducer. And here's why. And I'm going to have to draw something. I'm going to unshare this heart for a moment here. And I'm going to share this. All right. Now, do you all see this Word document here?
Yes.
All right. Now, all right. So what I'm getting ready to draw some blood vessels. So actually, so since we're dealing with the arterial system, this is an artery. All right. These are arteries. All right. I'll designate that left and right so I can ask you a question. Which artery is dilated or considered dilated? All right. So the right side is considered dilated. Let's say this is the heart. Forgive me for my writing, my drawing. It's rather jacked up, I know. All right. So remember when I explained to you all that the arterial system is constricted, and therefore that's what causes you to have a higher afterload?
Yes, sir.
If I gave this patient a nitrate, and remember, this is your left ventricle, right? Let's say this is the aorta, aorta here, going to this dilated blood vessel versus one going to this more constricted blood vessel. As the left ventricle pumps, continues to pump, does it take more blood to fill this space or to fill this space?
The right side.
The right side, exactly. If it takes more blood to fill this space, will it not take longer for this blood to eventually get back to the right side of the heart?
Yes, sir.
It will take longer.
Yeah.
And so if it takes longer, because remember, as the heart is pumping, its stroke volume, its ejection fraction, its cardiac output, as this blood is being pumped into this much larger artery, due to nitrates, right? This is due to nitrates. Right? This is due to nitrates. And so it is going to take a certain amount of blood to fill up this space. And therefore, the blood is leaving the left side of the heart, going into the systemic circulation, and eventually will return to the right side of the heart. But it's going to take longer to get back to the right side of the heart. Now, if it's taking a little longer to get back to the right side of the heart, aren't you buying the heart a little more time to not have to receive so much volume? See, the heart is receiving less volume over a period of time because these vessels are dilated now. So you're reducing the amount of, or you're reducing as far as time-wise, the amount of blood return to the heart. In other words, this side may take 10 minutes for the blood to return to the right side of the heart. But if they were constricted like this, it may take 5 minutes. If it took this period of time, then it gives the heart some time, all right, to handle the amount of volume coming back towards it. coming back towards the heart. It just buys the heart more time. Does that make any kind of sense at all?
Yes.
All right. Anybody, does that not make any sense to anybody?
I'm lost because I'll be thinking that the one that is more dilated will bring more blood back to the heart. So it would be pumping more blood to the right side. I don't know, maybe.
Well, but remember, it's taking more time to fill. It's the space that we're talking about. You see this space? This is a much wider space. So it's going to take more time to fill this space and less time to fill this space.
Okay.
So if it takes more time to fill this space, what it basically means is, because of these nitrates, it basically means that that blood return that will eventually return to the right side of the heart is slowed down a little more because it takes a little more time. All right. The same amount of blood volume is returning to the right side of the heart, whether it's dilated like this or constricted like this. But it's just that when you use nitrates, it just takes more time for when that blood is pumped out of the heart. As it's pumped out of the left ventricle, it takes time to fill that larger vascular space. And because of that, all right, because of that, it buys the heart more time. So remember, you're trying to reduce that afterload. You're trying to reduce, you're trying to reduce the preload. It works on the afterload as well, but the nitrates also works on the preload. See, some of these drugs may do both, but in this case, I'm just dealing with, just to make it easier for you, the nitrates, it is reducing the preload by, it's making more time. It's giving you a little more time because it's going to take more time to fill up this vascular space as opposed to this small space. If you had to fill up a house, or you have two houses. One of the houses is 2,000 square feet. That's this one. And the other house is 500 square feet. Will it take you longer to fill this house or this house with furniture?
Longer for the bigger one.
Exactly. It takes more. It takes a whole lot more time to fill this space, the 2,000 square foot home. All right. So again, in this case, it may take 10 minutes for this blood to return back, and this is just arbitrary and hypothetical, but it may take 10 minutes for this preload. This is the preload. It's going to take a little more time for this preload to eventually return to the right side of the heart. But if that space is more narrow, it gets there a whole lot faster. Do you want that preload coming back to the right side of the heart too fast?
No, sir.
No.
You do not. Because why? The heart is what? It's sick, right?
Correct.
The heart has failed as a pump.
Harder.
You're making it work harder. Exactly. You're trying to reduce that preload, so you're buying yourself some time by dilating those blood vessels. So that's why we refer to it as this particular drug as a preload reducer, because it's just reducing the amount of preload that is returning to the right side of the heart. It just takes more time. Does anybody still not understand that?
No, sir.
Miss Sylvia? Is she still on?
It is much better.
It's much better?
Yeah, this is Elizabeth. I'm saying it is, I definitely understand it a whole lot better too.
All right. All right. All right, now, so that's the preload. Let's see. Now, of course, when we talk about this same drug while I'm on it, we're talking about the same drug being also an afterload reducer. It's only because it dilates these vessels. So if you dilate these vessels, then that means the left ventricle has to pump against less pressure. Remember, your afterload is the amount of force the left ventricle must overcome to eject its volume into the arterial system. So if we give this patient a nitrate, we're also dilating the arterial system. So it can be referred to as an afterload reducer as well as a preload reducer. Does that make sense?
Repeat that.
All right. So this is the arterial system here. Mm-hmm. If I give this patient a nitrate, is it not going to dilate the arteries?
It will dilate.
It will dilate it. And if it dilates it, does the left ventricle have to work too hard?
Not as much.
Not as much. Exactly. Exactly. Because if before we give the nitrate, it looks like this. So we're looking at a blood pressure of, let's say, 190. This is just hypothetical, 190 over 20, right? Do you want anybody to have that kind of blood pressure?
No.
Sir.
Exactly. So once I give the nitrate, now we brought them down to what?
Probably like 120 over maybe 60.
All right. Is this not the pressure we want? Right? Because when you have this pressure, that means that your afterload is very high, meaning you have hypertension. And the left ventricle has to work very hard to overcome that pressure. Does that make sense?
Mm-hmm.
This is the goal right here. This is the goal right here. All right, that's the goal. The goal is to get that blood pressure down, because when the blood pressure is relatively normal, then we have an adequate afterload. The afterload is not too overwhelming for the heart.
I have a question.
Yes.
Let's say that they're on nitrates for a long period of time, or a diuretic for a long period of time.
Mm-hmm.
After them taking that so much or being in their system, could that cause someone's blood pressure to constantly be low? Could like that dilate completely enough the arteries out where now consistently they don't even have to take the diuretic because their blood pressure is low?
No, that won't happen. It makes sense. No, that won't happen.
Okay.
And this is why these patients have to continue to be on these medications, in many cases for life, unless let's say you have a patient who is obese, eating the wrong way, sedentary, and so forth. Let's say patient is 300 pounds, 5'0", but they lose that weight. Now they're down to 120 pounds. Well, they may not have to be on antihypertensive medications anymore, because that may have fixed their blood pressure issue. But as far as the medications are concerned, you have to pretty much be on it for life unless you make some lifestyle changes. And even that sometimes won't change anything. So you're basically on it for life. And your doctors are constantly titrating these medications up and down in order to adjust depending on what your blood pressure is. Your blood pressure, let's say, for example, you used to run 120 over 60, but for the last few months or so, your blood pressure has been 90 over 60. And of course, you might be symptomatic. Maybe there's some dizziness and what have you, some syncope and what have you. So the doctor may have to they have to change your blood pressure regimen. Meaning they may have to decrease your dose, the dosage, may have to take you off that particular one altogether. So it just all depends. Sometimes, just so you all know, they use they use a diuretic to help your blood pressure, to reduce your blood pressure. And these are particularly for patients who cannot handle certain antihypertensive medications. And so when you reduce the volume of blood in your vascular system, it causes your blood pressure to decrease. And usually they give them hydrochlorothiazide. Let's see, everyone, if you all can be back at 11:15. All right. Be with you all in a moment.
Hello, Professor William.
Yes, I'll be with you in a moment.
Yeah, I was just gonna say when you were asking if I understood it, I did, but I actually lost the voice this thing on my phone. I was talking back that I did, but you couldn't hear me.
Oh, all right.
Yeah, but I was hearing your lecture, but you couldn't hear me. But
Yeah.
I just switched back to the computer, the desktop.
Uh-huh. All
Yeah,
right. So,
yeah. So I just said, let me acknowledge that I understood it. Thank you.
oh, good, good. All right, good. Let's see. Get ready to share again. Nope, I don't want that. All right, can you guys see my desktop for my presentation?
I can.
What in the world? Huh. All right, so the last thing we didn't talk about as much as contractility, and that's just dealing with the heart muscle, which we know the heart muscle can be damaged, especially when you think about a patient who they may have an AMI or an acute myocardial infarction, and that can damage the heart muscle cells, causing the muscles to become weaker, or they can be just become weak due to this overworking of the heart. So again, we're talking about drugs that can enhance or strengthen the contractile force of the heart muscle. So we have drugs to decrease our preload. We have drugs that can decrease our afterload, and we also have drugs to increase our myocardial contractility, or the contractions of the heart. So keep that in mind. A few terms I want you all to also be familiar with. We talk about the stroke volume. And what that is the volume of blood that is pumped from the left ventricle per beat. So every time your heart beats and that blood is pumped during that time, it is referred to as the stroke volume. We also have another term referred to as the cardiac output. That is the amount of blood the heart pumps through the circulatory system in 1 minute. All right. And the last term I want you to be familiar with is called ejection fraction, or we may also refer to it as the percentage of EF. It is measured in a percentage or expressed as a percentage of how much blood the left ventricle pumps with each contraction. So for example, if you have 100 cc's of blood in your left ventricle, and when the left ventricle squeezes, it pumps 70 cc's out of the ventricle, of the left ventricle, you have a 70% ejection fraction. All right. Now, the normal ejection fraction is between 55 to 70%. Most patients become symptomatic with heart failure when their ejection fraction is about 35–40%. Any questions?
So you said the ejection fraction is the amount of blood pumped from the left ventricle?
In percentage, it's the percentage. So if you got 100, the reason I say 100 cc's, it just makes it easier for you to understand. So if 100 cc's of blood in the left ventricle, and let's say when the ventricle squeezes, 50 cc's is ejected, then your ejection fraction is what? 50%.
Right.
You got that?
Mm-hmm. So it's
All
a
right.
percentage of blood.
Yes, that is ejected.
Okay.
So now when we're thinking about heart failure, we need to be thinking about the stroke volume, the cardiac output, the ejection fraction. It's the amount of blood that is basically leaving the heart, all right? Described in different ways, of course. And so this is the reason why these patients are becoming symptomatic. They're becoming symptomatic because that stroke volume, that cardiac output, that ejection fraction is reduced for whatever reason. All right, well, reason being for whatever reason someone has heart failure, that is. But the amount of blood leaving the left ventricle will be diminished. It will be, and it will cause the different symptoms that we will be talking about. All right. So if you don't get enough blood that is being pumped and you're not getting enough blood perfused to your brain, what kind of symptoms do you think this patient will have?
Weakness, dizziness, confusion.
Exactly. Now, if you don't have enough blood being pumped to your muscles, what kind of symptoms would you have?
Maybe weakness.
Yes.
Not be able to move.
Well, you'd be able to move, but I mean, you'd be tired, fatigued, weak, right? You don't, all right. So you don't get enough blood pumped to your kidneys. What can happen to your kidneys?
Shut down. They can shut down.
Exactly. All right. So just think about these things as we talk about this. All right. Now, these are the priority concepts here. Perfusion, obvious. That's very obvious. And of course, we have the interrelated concepts for this chapter: gas exchange, comfort, as well as immunity. All right. Maybe you guys will now understand why I had to kind of take my time with this, because this can be a pretty complicated system. And this is why I tend to do a combination of voiceovers and also live lectures, because I can commentate during the live lectures. You can ask questions, we can have a discussion about it, and hopefully I can elucidate the information a whole lot better during the live discussions, if you will. All right. So we're talking about heart failure, also called pump failure. And it is the inability of the heart to work effectively as a pump. Now, there are different types, left-sided, right-sided, as well as high output failure. The latter one is rather rare. All right, but you will likely see, you definitely see the left-sided heart failure and right-sided heart failure in the clinical setting. This is a common chronic disorder resulting in acute episodes leading to acute hospital admissions as well as readmissions. Heart failure can result from acute coronary disease. It can also be due to structural and functional problems of the heart leading to acute heart failure. And of course, without saying, this is a life-threatening condition if not treated properly. All right. Now, the left and the right ventricles are the two pumping systems. One can fail, but most of your failure is from the left side. And always remember, most of your failure is the left side, and it progresses to the right side again if it's not treated properly. Because remember, the right side of the heart has to pump its blood towards the left side eventually. You know, as blood returns from the right side, it's being pumped from the right atrium, right ventricle, through the pulmonary artery, and again towards the left side. But if the left side is backed up, because the left ventricle is impaired, so will the right side begin to back up as well. And that right ventricle will have to pump against all that pressure now. See, the left side had to pump against all that pressure as in hypertension, and now it's backing up on that left side. Now the right side, as it tries to propel its blood forward, but now it cannot. And since it cannot, because it's going against so much pressure, it now begins to fail. And so now we're looking at left-sided heart failure symptoms as well as right-sided heart failure symptoms. And this is why when the sooner we treat someone with left-sided heart failure, we can preserve the right side. All right. Now, left-sided heart failure was formerly, and sometimes it's still called congestive heart failure. All right, but not all left ventricular failure involves fluid accumulation. So now, when you're thinking about heart failure, it can be either acute, but it can also be chronic. Think about acute in terms of, let's say if a patient's blood pressure goes up very high for whatever reason, maybe they're in a lot of pain and it stays high for a long period of time, the patient can go into acute failure. Of course, the chronic type is over a long period of time. The left side of the heart has had to pump against all that pressure. And of course, it becomes more of a chronic situation as opposed to acute. We also have subtypes of heart failure. The subtypes will be your systolic type of failure, as well as your diastolic heart failure as well. And we'll discuss what those mean also. All right. Now, when I talk about a systolic heart failure type, it means that the heart cannot pump with enough force during systole, not asystole, during systole. In other words, squeezing. Rather systole is squeezing, and diastole is relaxation. So you have to remember that as well. So with your systolic heart failure, the heart cannot provide enough force, contractions, in order to pump blood into the systemic circulation. So as a result, these patients have a low ejection fraction. They'll have a low ejection fraction because the left ventricle just cannot squeeze strong enough. So the ejection fraction would be lower than, let's say, the normal range of 50 to 70%. All right. It could decrease to as much as even 40% or even lower, actually. All right. And it is at that time is when these patients will begin to become more symptomatic, when that ejection fraction falls below 40%. And by the way, those terms that I gave you are from the previous slide, I believe, with the stroke volume, cardiac output, and so forth. I have all that written in the notes, so you'll be able to see that when you begin to study for your test. All right. Now, remember, as the percentage of blood volume decreases because of this poor pump, tissue perfusion is also reduced. And as a result, this blood begins to back up and it begins to accumulate in the pulmonary vessels. All right. Now, you will also have a chance to read in your textbook the signs and symptoms related to the left side of the heart. I think
it's freezing.
It's freezing? Can you see it? I mean, you know what? Oh, all right. Can you see that?
Yeah, now it's working.
All right, good, good. All right, so when we think about heart failure or AKA forward failure, because remember the left ventricles are pushing the blood forward, and so we have forward failure when it is unable to do so. Again, this is resulting from this dysfunction of the left ventricle. Because of this, as I mentioned to you earlier, your cardiac output will also decrease. And blood begins to, or this fluid begins to back up into your pulmonary as well as your systemic circulation. These patients, they are at high risk for sudden cardiac death. And when their ejection fraction falls less than 30%, they will eventually need what we call or refer to as an ICD or implantable cardiac defibrillator. And if you read chapter 34, it does talk about the implantable cardiac defibrillator. All right. Let's see. So, so you all should understand by now that the amount of blood in the ventricles before they squeeze or before systole is called the preload. And this amount increases, or the preload increases because blood is backing up and it cannot propel forward. Now, the amount of force the ventricles must overcome in order to eject blood into the systemic circulation is also called afterload. This increases as a result of, again, peripheral vascular resistance, or AKA hypertension. And we talked about that as well. All right. Any questions so far?
No, sir.
All right. Now that was systolic failure. And these are just the different subtypes. So it kind of gets a little confusing, but if you just kind of just look at them separately, then you understand what constitutes systolic failure versus diastolic failure. So with systolic failure, you have poor contractile force, right? With diastolic heart failure type, the left ventricle cannot relax adequately during systole or diastole or rest. You want your ventricles to rest long enough so that they might fill up with an adequate amount of preload or an adequate amount of blood. All right. So this is why it is important for the left ventricle to relax for a certain period of time to fill up with blood or to fill up with the preload. If the ventricles cannot relax enough, or if they become too stiff to hold enough blood, does your cardiac output increase or decrease?
Decrease.
It decreases. What are the general symptoms of a decreased cardiac output that you all can think of?
Weakness.
Yes.
Fatigue.
Yes.
Decreased blood pressure.
All right. It's kind of universal in the sense that anything that is causing you to not have an adequate cardiac output. You know, these patients have hypotension, they have a low blood pressure, they have cardiac arrhythmias, they have chest pain, they have clammy, cool skin, they faint, they have syncope, and so forth. So just keep that in mind that these are pretty much, whether it be from bradycardia, because they're losing their blood pressure, whether it be because of a tachyarrhythmia, because their heart is beating so fast that there's no adequate filling of a preload because the heart is just beating too fast. All right. So the cardiac output is reduced when the ventricles cannot relax, when we're talking about diastolic heart failure. And of course, as the ventricles become less compliant due to more pressure is needed to move the blood forward. So the left ventricle must be able to rest long enough. Now, you can see, this can be seen in about 20 to 40% of the population, but primarily you will see this in the older population and also women who have chronic hypertension, or if they have a CAD that goes undetected as well. As far as treatment for diastolic and systolic failure, they are similar. Some of the causes of heart failure is hypertension, CAD, and also valvular disease. And while I'm here, I might as well go ahead and show you all this. Let's see. There's a little drawing. All right. I want you all to be able to understand what I'm getting ready to show you here. All right, you all see this drawing right here?
Yes, sir.
All right, I'm gonna take that out. All right, so I just mentioned to you some of the reasons why someone might be in failure. So when the arterial system is constricted, that left ventricle has to pump against all that pressure, right? That's an increased afterload. That's to pump against all that pressure. So that causes the left side of the heart to do what? To fail. Mm-hmm. Now, let's say if this patient has, all right, so you have hypertension, but now you also have CAD. We know what CAD is, right?
Yes, sir.
So now look at this. All that plaque within the arterial system. Now when the left ventricles pump its blood, not only is it pumping against all that pressure, but it's also pumping against that narrow space. So that can also increase your afterload, right? That's CAD. Now, let's say this is the aortic valve. Can y'all see that valve?
Mm-hmm.
All right. So this is your aortic valve, because the your literature talks about valvular disorders. Patients who have disorders of their heart valves can also lead to heart failure as well. And I just want to show you how. So let's just say this is what we refer to as aortic stenosis, meaning this this opening is very narrow because these valves are defective. They may be calcified, they're defective, and so they barely move. And so they create this very small space. And so when this left ventricle ejects its blood into through the aortic valve, and this aortic valve cannot open fully, is this pressure high or low? High. So the pressure is high. If the left ventricle has to pump against all that afterload, that high pressure afterload, will the heart eventually fail?
Yes.
Yeah.
Yes. So you all now understand why hypertension, why CAD, that narrow space that's created, and why a valve disorder can lead to heart failure, because the heart now has to pump, has to go against all that pressure. And while I'm at it, let's say, all right, so this is the heart here. I know it's a mess. All right. Now, this is the myocardium here. This is the thickness of it. And I told you that the right side is much more thin. All right, because if the lower pressures over on the right side and higher pressures on the right side, excuse me, the left side. Now, let's say the left side of the heart has to pump against all that afterload, right? It will become even bigger. It has to become bigger in order to overcome that pressure. All that pressure, right? Now it's bigger. The collateral blood vessels, let's say, for example, when it was the normal size, all it required, and this is just to make it easier for you to understand, if it was a normal size, all it required was 3 blood vessels. Now that it has increased in size, you still have maybe, well, you may have now 4 blood vessels, but not enough to feed that larger muscle, cardiac muscle, right? This is a compensatory mechanism, by the way. The heart has to compensate so it gets bigger in order to try to overcome all that pressure. So you have, as far as ratio, a lower ratio of blood vessels to heart muscle, to a larger size muscle that it cannot adequately supply with oxygen and blood, nutrients, and so forth. So this tissue becomes more starved, it becomes hypoxic, right? And any tissue, a muscle that has to become, that is starved of nutrition and oxygen and so forth, it becomes what? Impaired, right? It doesn't function properly.
Mm-hmm.
But of course, if you have enough, if it can grow at the same rate as this muscle grows, then you wouldn't have a problem. Unfortunately, that's not the case. That's not the case. All right. So a small amount of blood vessels to a much larger myocardium that has gotten larger because it's having to work so hard against all that pressure. All right. And we'll talk about one of these. I'll briefly mention it again when we talk about the compensatory mechanisms that you all really want to hear about. All right. Let's see. So I just wanted to kind of give you an idea of the causes why this is happening. All right. Now, does anyone know why pulmonary congestion occurs in heart failure? Tell me what is happening.
Blood's back in the pulmonaries.
All right, say that again.
The blood backs up into the pulmonary system.
All right. Now, is that pressure that is created by the backing up of the blood, is it high or low?
High.
Right. So when all that volume begins to back up into the pulmonary circulation, that pressure increases more and more. That volume has to go somewhere. And you know where it goes? Into the lungs. It goes into the lungs. Well, some of it goes into the lungs. All right. And this is why these patients have what? Crackles. When you auscultate lungs, breath sounds, and you hear these crackles, it's because that blood is backed up, that pressure is increasing, and that blood it begins to seep into the lung tissue. And so when you auscultate breath sounds, you hear crackles. And if it gets too severe, they develop pulmonary edema because the alveolar capillary membrane becomes thickened, all right, with more fluid. The more fluid leaks into the AC membrane, it gets thicker. And well, let me show you this again. Let's see, where is it? All right. So, all right. So, all right. Now, your alveolar capillary membrane, let's say normally it's this thickness, right? Let's say this is normal. When that blood volume begins to back up into the left side of the heart, that AC is called the AC membrane, or alveolar capillary membrane, right? Now, when that fluid begins to leak into this membrane, because remember, this is where, let's say if this is exterior, internal. So when you inhale, oxygen comes into our bodies. When you exhale, it goes on the outside. But what happens here is, see, this is where oxygen and CO2 exchange is taking place, right? This is where it's taking place. But when all that volume begins to, when a certain amount of that volume begins to fill up this AC membrane, it now becomes thicker, meaning it is edematous. Because of all that volume. And so let me ask you, if it becomes this thick, all that's fluid in there, will you have adequate exchange of oxygen and CO2?
No.
Right. Why?
You can't perfuse the water.
Thank you. It would be very difficult for that CO2 to go this way and for oxygen to come back in. Be very difficult. And this is one of the reasons why we give Lasix, because we want to reduce that amount of edema, that swelling, hopefully. All right, so that gives you an idea how that works. Is that a little clear for you all?
Mm-hmm.
Let's see, where am I now? All right, well, I got back to it. Now, I talked to you guys also about right-sided heart failure. And right-sided heart failure can be due to left ventricular failure, meaning the left ventricle has failed as a left-sided heart failure. It can also be due to a right ventricular MI. So, you know, when these patients have a heart attack, you know, you're not getting blood beyond that point of where there may be an occlusion or whatnot. And so that muscle that now is not receiving any blood will begin to die. And of course, this patient goes into right-sided heart failure. So if a patient has a right ventricular MI, it can also lead to right heart failure and also pulmonary hypertension. Sometimes patients may have, let's say, for example, COPD, and the lungs are severely damaged, and the pressures in the pulmonary system are really high, and they have what we call a pulmonary hypertension or hypertension within the pulmonary system. And so the right ventricle has to pump its blood against all that pressure. No different than the left side has to pump its blood through the aortic valve into the aorta. And if it's constricted or clamped, then that's a lot of pressure for the heart to overcome. Same thing on the right side. That's a lot of pressure for the heart to have to overcome. All right, so these are the reasons for right-sided heart failure, and never forget that. I'll let you go ahead and read about the high output failures, but this is quite uncommon, but just go ahead and read about it anyway. Basically, with the high output failure, anything that can cause an increase in metabolic demand, such as like septicemia, high fevers, anemia, and hyperthyroidism, something that causes the heart rate to really increase because the metabolism is really up as well. Well, these conditions cause an increase in metabolic needs. So you have this high heart rate, and the high heart rate leads to a high cardiac output. So the cardiac output is not really affected as much in this particular condition. All right. But it's, like I said, it's uncommon, but know about it anyway, just in case. All right, let's see. I already talked about quite a bit of this information here. Kind of like a bit of duplication, but let me see what I didn't talk about. All right, so we talked about this already. All right. Now, with your right-sided heart failure, and we talked about what conditions can lead to that. Again, the right ventricle cannot empty completely. The volume increases and pressure develops within the venous system. Remember, on the right side, we're talking about the venous system, and on the left side, we're talking about the arterial system. Remember, the right side is bringing deoxygenated blood back to the heart, and the left side of the heart is taking away oxygenated blood away from the heart. All right, so just remember that. And of course, when the right side is failing, these patients begin to develop peripheral edema, and this is when you also might see that pitting edema, excuse me, wherein you place a pressure with a finger on one's lower extremity, and that indentation stays for a certain period of time. Also, one of the symptoms that these patients with right-sided heart failure may have is hepatomegaly, meaning an enlarged liver. They might have a distended jugular veins, or JVD. Also increased LFTs, increased liver enzymes, in other words. Because all that engorgement in the liver can also begin to become impaired. And so if you did blood work on this type of patient, you drew their liver enzymes, they will be elevated. These patients may also have anorexia, and this is because this blood, as it is backing up on the right side, is backing up into the GI vascular system, and all that swelling in the gastrointestinal system, all that swelling causes this patient to feel full early, and they also may have anorexia, loss of appetite. Remember, the liver is all a part of the GI system as well. Y'all do remember that, right?
Yes, sir.
Yes, sir.
Good, good. Let's see. Now, this is the high output failure. We talked about that already, so just make sure you read that as well. All right, so now this is the fun part here. Unfortunately for you guys, all this is already done for you. It's already written for you, meaning probably better to just listen as opposed to trying to write down stuff all the time. You know, I think that just takes away from students' ability to listen. So I try to make it a little doable for you. Actually, before we delve into this one, go ahead and give me a 15, be back at 11:15, excuse me, 12:15. I want your mind clear before we go through this. It's not that bad. It's not that bad, really.
What time are we coming back?
12:15, Sylvia. 12:15.
All right. Let me hang up.